We're here with Dr. Aszmann. First of all, we would like to thank you for granting us the opportunity of this interview. So, nerves are something very complex and fragile. Therefore, they are often susceptible to injuries. As your expertise is rebuilding peripheral nerves, what can you tell us about this subject?
God, this is an entire lecture.
Yes.
So nerves indeed are very, very sensitive structures. One thing that I may say here in this interview, because we have such limited time, is that the majority of nerves are actually sensory nerves. So they convey information from the hands and arm into the brain. And the minority, only 10% of these nerves are efferent. So that means of these 350 nerve fibers that we have that come out of the brachial plexus, only about 30,000 nerve fibers are communicating with muscles. So we have only very little to play with, and we need to be very careful in reconstructing peripheral nerves, where we take them from and where we put them at. So for example, one of the latest things in nerve surgery is nerve transfers. So we take nerves that are very special to hands, for example, and we transfer these nerves to gain some function that we expect from them. That is totally different from what we have done 20 years ago, just reconstructing a peripheral nerve. So we don't do that any longer. We do sensory or motor nerve transfers.
Okay. So does every kind of nerve injury has a solution, or?
Yes and no. Yes, if it's an infraganglionic injury, meaning if the injury is beyond the spinal cord. So for example, if somebody takes a knife and cuts the arm and the nerves are divided, yes, we can reconstruct these nerves. If there's nerves torn out of the spinal cord where they're stretched, it's difficult for them to be reconstructed because we cannot implant nerves into the spinal cord. We can, but it's not going to work very well. So we can reconstruct peripheral nerves, but only if the nerves come out.
Okay, so which one are the hardest?
The most difficult, I think, are stretch traction injuries because it's difficult in diagnosis. As you may know as medical students, the most important thing is a proper diagnosis. In surgery, it's an indication for treatment that delineates from the diagnosis. And stretch traction injuries are difficult to diagnose in the extent of nerve surgery, for example. And so we need to be I think the most difficult is to come to a proper diagnosis and indication, and stretch traction injuries are difficult to diagnose.
And do you think that in the future these obstacles may be overcome?
Yes, by teaching medical students. I think I can tell that I'm now over 50 years old, and I've been doing teaching and doing research myself for many years. I can say that in my trade, which is a surgical trade, I think apprenticeship, meaning that you have a student with whom you invest a lot of time in teaching, I think that's the most important thing to overcome false diagnosis, false indications. So I think it's not so much maybe neurobiology or I don't know what, but it's just having proper teaching.
So in simple words, can you describe what is a bionic hand and how does it work?
A bionic hand is a concept. It's not a specific treatment per se, but it's a concept of dealing with patients that have lost hand-arm function, and that we augment mechatronic support by nerve transfers, muscle transfers, but various techniques of plastic surgical armamentarium to make the mechatronic device work best. So for example, we have seen that today, that some patients that have lost their arm, how do I get all the information out of the arm, out of the nerves into this mechatronic arm? So we work at the biotechnological interface. So that's what we actually do. We improve the body's capacity to communicate with the machine. And that's what we call bionic reconstruction.
Okay, so we can control the bionic hand. And what about fine motor skills? Are they insured?
Yes, so fine motor skills, that's something that we work on now. I think it's not yet possible, not because the mechatronic hand would not be able to do that, because we can have mechatronic hands that move their fingers. But the problem is that we need to find ways ways to get this information into the machine. The problem here is that we have very crude signals that we need to use. These are nerves that talk to muscles. And now with newer techniques, we make muscles more intelligent. These are our translators. These muscles are translating neural information into usable information for us. And then we're developing small implants that can pick up that information and translate it into mechatronic function. Now I think that will probably, hopefully within the next 5 years, we will have some hands that will work with individual finger movement.
Can you please explain in a nutshell the implementation process?
Implementation is, as I said before, rehabilitation. That means that we need to train the brain of the patient. Once we've done all these nerve transfers, we need to teach the patient what has happened. And so that means we have physiotherapists that talk to the patient. That's me talking with the physiotherapist, so the physiotherapist knows which nerve transfers have been done. And then we train the brain of the patient. That may take 2 weeks. That may take for some other patients half a year. And then once they have understood as to what's happening and how they can address the machine and all that, then it's a successful outcome. I need to say in this regard that there are some patients that may not have the psychological skill, either they are disabled in some form, that we need to obviate treatment. So we say, you have a need, but you don't have the capacity for the technology, so we will not treat you.
So that takes us to our next question, actually. Are there any criteria for these implementations?
Yes, there are. It's important that the patient is dedicated, that he has a strong wish to have hand function back, because it's a long process for him to get there. It's financial issues that need to be cleared beforehand. And obviously, yes, anatomical requirements, that if the patient has an avulsion of all roots, it's nothing we can do. And actually that unfortunately happens. I've seen a patient last week that came from Australia. And I needed to tell him after an hour of investigating that he's not a candidate for a bionic reconstruction. So we need anatomical requirements that really he has nerves to work with, psychological, then also social environment, that he has a family and people that take care of him in the greater range, and obviously also financial burdens that need to be overcome. But then again, a car is about, what, 20,000 euros? A hand here is about the same price. I would much rather have a new hand than a new car.
So can the bionic hand be considered a functional hand, or is it just another prosthetics? Or is there room for improvement?
It is a prosthesis, no doubt. Yeah. Prosthesis in the sense that it takes care of a lost body function. It's a reconstruction on a very poor level, in fact, because the majority of the hand is sensory function. I go into my pocket and I tell you what's inside. You don't know, because I say, let me look. And in fact, it's this. Yeah. And so that means that the sensory function of the hand must not be underestimated, and a prosthesis at this point can only establish motor function. And this is a big problem. But that's all we can do at this point, so it is still a prosthesis. A bionic hand can move fingers. Yes, it will be able to move all kinds of things, but it will never be sensate. But, and we heard that in my talk, it's part of the human being. That is an important concept, I think, because as long as the patient incorporates it into his body image, he will deal with this as if it's his own. It's very similar as you drive a car and you crash it, you say ouch. You say ouch because it's going to cost you a lot of money. It's not because you hurt your skin. So these patients are very careful with the machinery because they know it's valuable to them. Not because it's expensive, but because it transmits function.
So that's all our questions for you.
Okay, wow, I thought there's going to be more.
I hope you're enjoying our Congress, and thank you very much.
Yes, thank you also
for your contribution.
Yes, thank you. Thank you.
I have a lot of questions. So